Hello friends, today I am going to discuss with you about executive summary of recommendations of Green-top Guideline number 20A. This guideline is about external cephalic version and reducing the incidence of term breech presentation. So executive summary of recommendations is: how effective is ECV in preventing non-cephalic birth? Women should be informed that the success rate of ECV is approximately 50%. Women should be informed that after an unsuccessful ECV attempt at 36 weeks of gestation or later, only a few babies presenting by the breech will spontaneously turn to cephalic presentation. Women should be informed that few babies revert to breech after successful ECV. Women should be informed that a successful ECV reduces the chance of cesarean section. Does ECV affect the outcome of labor? Women should be informed that labor after ECV is associated with a slightly increased rate of cesarean section and instrumental delivery when compared with spontaneous cephalic presentation. Can the success of an ECV attempt be predicted? ECV success can be predicted to some extent, but the use of models to predict success should not be used routinely to determine whether ECV can be attempted. What methods can be used to improve the success rate of ECV? Use of tocolysis with beta mimetics improves the success rates of ECV. Routine use of regional analgesia or neuraxial blockade is not recommended, but may be considered for a repeat attempt or for women unable to tolerate ECV without analgesia. When should ECV be offered? ECV should be offered at term from 37 completed weeks of gestation. In nulliparous women, ECV may be offered from 36 weeks of gestation. What are the contraindications to ECV? There is no journal consensus on the eligibility for or contraindications to ECV. Women should be informed that ECV after one cesarean delivery appears to have no greater risk than with an unscarred uterus. What are the risks of ECV? Women should be counseled that the appropriate precautions. ECV has a very low complication rate. What measures are appropriate to ensure fetus safety? ECV should be performed where facilities for monitoring and surgical delivery are available. The standard preoperative preparations for cesarean section are not recommended for women undergoing ECV. Following ECV, electronic fetal monitoring is recommended. Women undergoing ECV who are D negative should undergo testing for fetomaternal hemorrhage and be offered anti-D. Who should perform ECV? ECV should only be performed by a trained practitioner or by a trainee working under direct supervision. How acceptable is ECV to women? Although most women tolerate ECV, they should be informed that ECV can be a painful procedure. How could the uptake of ECV be increased? The uptake of ECV is best increased by timely identification of the baby presenting by the breech and provision of evidence-based information. How can an ECV service be developed and audited? There is no evidence to support any particular service model, although larger institutions may consider a dedicated ECV clinic. What is the role of non-ECV methods? Women may wish to consider the use of moxibustion for breech presentation at 33 to 35 weeks of gestation under the guidance of a trained practitioner. Women should be advised that there is no evidence that postural management alone promotes spontaneous version to cephalic presentation. Thanks for watching. If you like my video, please subscribe to my channel and click the bell icon for more updates.